Good afternoon. This is Erin with the Department of Medicaid. It's not quite 1 o'clock and we are still clearing out the waiting room, so we'll give it just a moment before we get started.
Thanks, Aaron. Just tell me when you are ready to get started.
Yes, ma'am. It's about clear. Good afternoon. This is Erin with the Department of Medicaid. It's officially 1 o'clock and our waiting room is clear. I currently only show Wanda and Julia logged in. We also don't have enough active TAC members as of today to establish a quorum or approve minutes, but I will turn it over to you.
Great. Thanks, Aaron. Yeah, we've not met since October, sort of waiting for our new members to be appointed by the governor, but we wanted to regroup and just touch base and look at what we can work on for the rest of the year. So thanks everyone for coming. So I'm Julia Richardson. I'm one of the TAC members. We currently don't have a chair, but I'm going to be facilitating this meeting. And I don't know, is Leslie, is Deputy Commissioner here
I
to
have
say welcome?
I have not seen her log in yet,
Okay,
but I can keep an eye out for her.
great. And like Aaron mentioned, we won't establish a quorum or approve our minutes from the previous meeting. I will note, Aaron, I think you know that the website is undergoing renovation, I believe, and so the old minutes and things aren't posted. So I think that's just a work in progress, maybe.
So I went back and reviewed, and your minutes were not posted because you guys haven't had quorums. So I can provide them to the TAC if they're needed, but they're not on the website for that
Got
reason.
it. Got it. Okay, thanks.
But
And then we
that
we
was
did
the
have.
issue on some things. We did have some things that didn't convert over. So
Got it. Okay, thank you. Okay, so we'll just jump into old business. And the first thing is um, deciding on an incoming chair, which we'll do in the future. But any updates on the new members coming in?
I can actually give that update. I have been in contact with my contact at the governor's office multiple times over the past few weeks. I've let them know if we could just get one or two more members, we would have enough for a quorum. I believe they currently have one reappointment application pending. And then we have two new members and their applications are pending. So as soon as I hear back from them, I will let you guys know, add them to the meeting cadence. And so that's something we're really been trying to hammer really hard. We're also using our social media platforms to try to start advertising some of the vacant positions that are on this TAC that we don't have pending applications for. So we're trying to do everything that we can to get that word out. We're looking to, fill these positions and how to go about um, filling out that application and getting it submitted. So we're really trying to do everything we can on our side to keep it moving. I follow up about once every 2-ish weeks because I don't want to be on the wrong side of the governor's office harassing them. So I do try to reach out fairly frequently. And so they are aware of the quorum issue. And so they're really trying to work on getting that taken care of for you guys.
Great, thanks. Any questions for Aaron on that? All right. So I thought just at the first of the meeting would be good just to review the purpose of this TAC. And so I pulled some data out from a prior document, and we were established in November 2020. Um, and our objectives are to review the strategies, policies, and procedures for populations covered under Kentucky Medicaid, to serve as an advisory body for the advancement of health equity and address inequity and reduce disparity gaps, and to make recommendations via the MAC to find ways to advance health equity. So that is why we are convening, just a little reminder. Um, and one of the first things that we had talked about when I think probably our first or second meeting was transportation access, because it's such an equity issue for the families we work with that are on Medicaid. And so I connected with Holly Hundle, and if Holly's on, she's going to give us an update on the non-emergency medical transportation sort of status of things from an advocate's perspective and some opportunities. So Holly, you can share screen, or Aaron has your presentation, either one.
I'm fine. Erin, do you want me to share screen or would you prefer to do that?
I always leave that up to the presenter. So you're welcome to share your screen. You are a
Okay.
co-host.
Let me do. Why can I never find that share screen button when I need it?
Bottom middle. And
There it is. It's
if you're,
green.
yeah,
It's
mine
green.
always moves, so I completely understand.
Okay, that's the screen. We're going to share that. We're going to put this into presentation mode. Okay, can everyone see that?
Yes, I can see it. Thank you so much.
Okay, thanks, Julia. So my name is Holly Hudnall, and as Julia said, I am with Kentucky Voices for Health. I am the Community Engagement and Education Director here at KVH. And for any of you that don't know, Kentucky Voices for Health is a consumer advocacy organization that's focused around healthcare. And we do a lot of policy work around healthcare in the state, trying to make sure that folks have accessible, equitable, high quality healthcare, no matter what part of the state that they're in. And we know that we've done a lot of talking to folks about transportation. And so I wanted to talk to you guys a little bit about that today. Just for a little context on NEMT, which is non-emergency medical transportation, it is a covered benefit for Medicaid members. So that part, Medicaid members fall under DMS, but NEMT is implemented by the Kentucky Department of Transportation. So we have two entities kind of that are in the mix when we talk about NEMT. And the Department of Transportation contracts with 8 different brokers in the 15 regions of the state. And those brokers are paid a capitated rate to provide transportation services to Medicaid members. So what that basically means is in each one of the regions, they calculate how many Medicaid members there are. That number of members is multiplied times the rate, and then that's what the brokers are paid to provide those transportation services. And on this slide, you can see how the different regions are broken down and who the different providers are. The Transportation Cabinet has publicly available information about NEMT delivery, and I have some links here. I believe that you guys will receive the slides, so those links are live. The last NEMT report that is available there is for fiscal year 2023. And if you are looking for information on NEMT on the Transportation Cabinet website, you will need to look for Transportation Delivery Branch. That the department that kind of maintains NEMT is the Human Services Transportation Delivery Branch. And so sometimes if you don't know what it's called, it can be a little hard to find that information on that Team Kentucky Transportation Cabinet website. So what you will be looking for is the tab that says Transportation Delivery if you're looking for that information. So we've been talking to folks about NEMT for quite a while. As I said, each year for the last 3 years that I've been here, we've done listening sessions with different communities across Kentucky where we invite community professionals like community health workers, peer support specialists, folks who really assist clients with using their benefits, accessing different services. And also we invite folks who are directly impacted. So people that are actually Medicaid members, to talk to them about the different issues that they see with using these benefits. We also talk to folks about NEMT when we're tabling at community events. We have roadshow conversations. So we have an educational forum that we do in different communities across Kentucky during the year, and just to give them updates on new policies, and information they need to do their job. And we talk to folks about transportation there. We field a lot of concerns for community professionals when a community health worker can't get a ride for one of her clients and she can't understand why. We get a lot of those calls, and then we can kind of escalate those cases with DMS and DOT to try to get them resolved. And we've also done advocating around regulation changes and legislative changes with administrators and legislators. So when we ask people across Kentucky, anywhere, Pikeville to Paducah, from Covington all the way down here in Bowling Green, what are the most concerning issues in your community? Transportation is always in the top 4 answers. Part of it is that Kentucky is a very rural state that doesn't have any public transportation, but even in our more urban areas that do have public transportation, transportation is still a serious issue for folks in those communities. So when we look at NEMT in practice and what we hear folks talk about, we know that NEMT is necessary. So we have about 122 Kentuckians who use Medicaid for health insurance, and they do not have a vehicle in their household. They're looking for a ride from a neighbor. They are trying to rely on public transportation. They're asking a family member to take them. They do not have access to a vehicle. And while it varies by county, we have counties in which 13 to 15% of households don't have access to a vehicle. Maybe that vehicle isn't working. Maybe they don't have a vehicle at all. Maybe they can't pay the insurance. There are lots of reasons that people may not be able to have access to a functional, accessible vehicle when medical transportation is needed. And for those folks, getting to doctor's appointments or to medical appointments is really, really difficult. So one of the biggest issues that we see, and I think it would be one of the easier issues to maybe fix, is that people are just unaware that NEMT is available. Many times when we go into listening sessions and we ask if people are aware of NEMT services, many of them don't even know what we're talking about. So for many Medicaid members and their caregivers, they just don't even know it's available. Another issue that we commonly run into is that people who would qualify under the new regulations that changed last year have not tried to access NEMT under the new regulations. They don't know that they've changed. So maybe they tried to get non-emergency medical transportation in the past. They didn't qualify at the time because their spouse had a vehicle in their name. And they are just like, well, I can't qualify for that because my husband has a car or my wife has a car. Under the new regulations, the requirement is that the vehicle be in the member's name. And so they don't know that they could be qualified now. So I think just making folks aware of that would be helpful. Another issue that we commonly hear about is that the regulations around the use of NEMT are burdensome. You have to call 72 business hours in advance to make an appointment. That means if you have an appointment on Monday at noon, you have to call that office 72 business hours. So Friday, Thursday, Wednesday, you have to call that office by Wednesday at noon to make that appointment for the next week. And for lots of folks, they simply, that's just a barrier for them. When you are trying to qualify for NEMT, if you have a vehicle in your name, but it is not working, or your husband has a vehicle, but he has to drive that vehicle to work and he can't take you, or a child, you have a child and they need to take that vehicle to school. You have to show documentation for that. And often that kind of documentation can be difficult for folks to provide. If you have a medical reason that you can't drive, we had a gentleman who broke his leg. And because of his broken leg, he could not drive. And him trying to get the documentation from his provider to an EMT to try to show, he had to miss several doctor's appointments because he couldn't get the paperwork in to qualify for transportation. So that documentation can be difficult for people to get. We also have an issue that the brokers are not required to uniformly train or use a standard intake procedure, and training materials may not be updated to the newest requirements. So, we've heard of, brokers having different intake questions. Maybe when the regulations first changed, not all brokers knew that they had changed. And so that's an issue as well. And then the third issue we most commonly hear is that customer service is a problem. So with the delivery itself. If you have an issue with an EMT, it is difficult to find the number to call and try to have that addressed. We also have parents and caregivers who talk to us about poor customer service, including safety violations, but they don't know that they can report the problem, or they are very, very concerned that if they do report the problem, there will be some sort of reprisal. For a lot of our folks that live in rural communities, in small communities, the same person picks you up every time. And so they're very afraid that if something happens and they report that person, they'll no longer be picked up. They'll be picked up late, or that they'll have to deal with some other kind of reprisal. We do have patients that often report missing appointments because they weren't picked up or they were picked up late. And doctors' offices often now have a no-show policy where they will dismiss a patient if they miss a certain amount of appointments. Usually 3, but I've heard of some physicians that have 2. So if your NEMT ride doesn't come and you don't get picked up, or you're late for that appointment, we have folks whose providers are dismissing them because they've missed 2 appointments. And that creates a problem for folks. Or when they are dropped off, they must wait for a long time, or they must call the dispatcher several times to be picked up to return home from the provider. It's another issue that we commonly hear about. We also hear from community health workers who serve non-English speaking populations that part of the problem is that when you call the broker, the phone prompts are very long, and they're often only available in English or Spanish, and getting interpretation for other languages is difficult. For example, when you call, one community health worker said, when you call, you have to push 1 8 times to get to the point where you're speaking to a person and you can ask for an interpreter. And so that, we've all dealt with phone menus, and that can be a very frustrating process to go through. We've also heard that, the intake questions may use jargon or unfamiliar terms, and that might be difficult for folks to understand. An example of this is the intake form may ask if the patient is ambulatory. Not everybody knows what ambulatory means. So you could just ask, can the patient walk? And that would make that much simpler. And then we also have a lot of language barriers between drivers, dispatchers, and passengers that creates issues. So we've advocated for several policy changes. Another thing that we did was we created, you can see it here on the left-hand side of the screen, a one-page non-emergency medical transportation explainer. And that is really geared toward letting people know what they have to be eligible, what an EMT is, and who they have to call. Also, who to call if they're denied a ride, or who to call if there is a complaint or a concern, and also what to ask for if you need an urgent care ride. So we try to distribute that. We also have this in Spanish, and we're working on having it translated into some other languages for folks to be able to hand out to people to just do more public education around NEMT. Um, it would be a really good idea if we could partner with providers and community professionals like CHWs and peer support specialists and case managers to kind of get the word out about NEMT and exactly what they're going to need. It would also be great to update that transportation cabinet website to make that information a little bit easier to find, and do more social media messaging about the service, including when they have opportunities for surveys and other user engagement. One of the things that happened last year was that there was a customer satisfaction survey or consumer satisfaction survey that was posted on the Department of Transportation's website. And I don't know how it was circulated. We never saw any messaging on social media about it. I just happened to be going to the website one day to look for something and saw that it was posted. And so surveys like that, it would be really helpful if those were distributed more widely so that more folks could take those, so that we could have an accurate picture of exactly what is going on with folks when it comes to NEMT. Another issue that we commonly see is that folks think that they have to have that 72 out, they have to call 72 hours in advance. So for example, if you have a person who's sick, maybe they have the flu, and they need to be seen by a doctor. They need to get in more than 3 days early. But if they don't have another way to get to the doctor's office, they think they're just stuck, or they call an ambulance and they go to the emergency room. So you can call the broker and tell them that you need an urgent care ride, and those are supposed to be provided within 12 hours. So if you're sick, you need to be seen at an urgent care, or your physician can get you in that day. You should be able to call that number, tell them that you need an urgent care ride, and get a ride that day so that you don't have to call an ambulance or sit at home and have your condition worsen. And we need to let folks know that that's available, because many of them don't. And even when we talk to community professionals, they're not aware that that's what they need to do to get a person a ride quickly. As far as regulatory changes, we could make it simpler for people to show that they can't drive or don't have a vehicle available. Removing that 72-hour restriction would also be helpful. It would be wonderful to standardize implementation and training for brokers, dispatchers, and drivers across all 15 of the service regions. So for example, if they had a standard intake form and everybody asked for the same information, and that was the information that was put in, it can make things much simpler for folks when they're trying to schedule rides. It would also be good to allow more subcontractors to provide NEMT services, particularly when we're talking about providers, because those providers have an incentive to get their patients to the doctor's office. And some providers do provide transportation, but many providers do not. So if they could be NEMT subcontractors and get their patients to the doctor's office, that would be a really welcome change for most people. As far as customer service, clearly posting information about how to report issues or safety concerns, and allowing for that reporting to be anonymous or at least de-identified. As I said, when we're talking about small communities, these people know the people who are picking them up. They might be their neighbor. They might live just down the road. Like they know who's picking them up, and that person picks them up every time. So they're very, very afraid of reprisals if they call to report something. And therefore they just don't call and report. They don't make a complaint. You know, if they knew that they don't have to call the broker, they can call the Department of Transportation to make their complaint, and that their complaint would be de-identified, then they might be more likely to speak up when something happens rather than being fearful of what could happen. Also, like I said, that number is really hard to find. And I wish they would just put a "How's my driving" sticker so that people have the number that they can call. It would be wonderful to have phone prompts in additional languages and try to pair clients with drivers who speak their language. And having, like I said, that uniform intake process. And we've also advocated for a study that looks at other delivery models for NEMT and modernizing that NEMT system. So I do want to give you guys some time to ask questions or make comments. I am really interested in hearing from you about NEMT and your thoughts and feelings on it. I tried to keep within my time, Julia, so I know I threw a lot of information out very quickly, but I welcome any questions, comments, or snide remarks. So
Thank you so much, Holly. That was really informative and reflects, what we had talked about in one of our earliest meetings back in 2021, probably, about how this impacts the whole state. And it's frustrating because it's not a Medicaid. It's not within Medicaid. It's an external partner, and what's the relationship between Medicaid and them, and how is that relationship, and how can we really advocate for improvement? So I'll just open it up for questions for Holly. So Judy's in the chat. She said, excellent presentation. You summed it up wonderfully.
What
I
is
do know there.
I have a question. What is like the utilization rate that you see that, what is the goal?
I'm sorry, can you repeat that question again?
What is like the utilization rate? How many people are currently using this service?
Sometimes utilization rates can be a little bit difficult to get, but it looks like, based on the data that we had available, that the utilization rate is being reported at like 17% in Kentucky. We don't have an overutilization problem with NEMT.
Okay.
Nationally, for NEMT services, the utilization rate runs about 4 to 5%. So what that means is, of all of the people that have Medicaid, that's
Right.
the percentage that's using it. So it's a very low percentage of folks that use it. And typically they will only use NEMT if every other option has been tried, right? Like, if you can get your aunt to take you to the doctor's office rather than have to wait for NEMT or call and make an appointment or jump through all these administrative hoops, that's what you're going to do. But for some people, that's just not like, they just don't have any other option. So the utilization, it's not overutilized. It's actually probably really underutilized. But it looks like, from the data that we've seen, it's somewhere around 17% maybe in Kentucky.
Okay. Right.
Rachel,
yeah.
I was just going to say, Rachel dropped in the chat, approximately 240,837 trips were utilized by Medicaid members per month from July 1, 2022 to February 28, 2023.
Okay.
Thank you, Rachel.
Thank you.
Thanks, Rachel. Where it gets a little tricky sometimes is finding out how. So NEMT services can be for any Medicaid covered service. So, for example, I have a younger brother who has a Medicaid waiver, and he does adult day services.
Okay.
So he has a driver that comes and picks him up every morning and takes him to adult day services and then brings him home in the afternoon. And then you have other folks who don't have that kind of, like, scheduled, daily use. And so they may use it once every 3 months, or they may use it, 4 times in a week and then not use it again for a month. So that's where utilization can kind of get a little tricky,
Right.
figuring who's using what and when.
Yeah, considering that transportation is such a barrier, especially in rural areas, will be interesting to see what is the utilization rate in rural areas, and whether we should focus on having some kind of a public campaign, maybe through radio or things like that to get the word out. Because sometimes we assume that people know that these services are available and they might not know. Um, I know that we, for example, in River Valley, the mental health center, we inform clients, and in some cases, case managers help them arrange for that transportation. But that is not the case for other Medicaid services that they may need. And so
Right.
this could be a good initiative at a local level with hospitals, for example, for us partnering with Owensboro Health and to get some kind of campaign out there, because transportation is probably the second biggest barrier for accessing care.
Right.
Thank you for that.
No problem. And I know that like we all and don't get me wrong, transportation is an absolutely huge issue in our rural areas, but it's also an issue in our urban areas. I know when I was speaking with folks in like Lexington and Louisville, they'll talk about public transportation and they'll say, well, you can get like a bus pass, but that public transportation doesn't take you door to door. So for example, they may have to go 2 blocks to the bus stop and then they're dropped off 3 or 4 blocks from where their provider is, and some folks just simply can't navigate that distance to use public transportation. So it is a huge issue, yes, absolutely, in rural areas, but it is also an issue in urban areas as well. And I'm afraid that sometimes we forget that because we think, oh, they do have public transportation.
That's
um,
correct. I agree with you.
Wanda, this is Erin with the Department of Medicaid. If the TAC is interested, I can always request that data. I see someone was asking about maybe the differences between, since the regulation has changed. So if that's data the TAC is interested in using, that's something I can request and have sent to you guys prior to your next meeting. We can break it down by region and maybe have, different years to show between when the regulation, excuse me, was updated.
That would be great. Thank you,
That would be
Erin.
great. Thank you.
Absolutely.
I have a kind of a granular question about if the car is in the person's name, and what if the patient is a child? What do they look at for that? I think that if Holly, if you know. Oh, I think we lost Holly. I
Oh,
bet she'll jump back in.
okay.
Great. When you see her, Erin,
So
let me know.
what was the question again? I think
Oh,
Holly may have frozen.
yeah.
This is
It was
Kelly
just
Colby with Kentucky Voices for Health. What was
oh,
the question? I'm sorry.
so with a assignment of a car or a vehicle, if it said if it's in the requester's name, but if the patient is a child, do they go by either? Like, how do they decide whether or not they have a car assigned to them or a vehicle assigned?
When the patient is a child and the ride is for the child, is that what you mean?
Yes.
They do still assess, like, because obviously a caregiver or parent has to be with that child. You can't send them to the appointment alone. I think the assessment would still apply, but that would actually be a good Jeremy Thompson or Justin Derringer question as far as like the administration. Jeremy is with the Transportation Cabinet and Justin is with Department for Medicaid Services as far as the technical broker approval.
Yeah. So
But
say, for example, mom's going to bring the child in and the car's assigned to mom, but dad has the car at work. So she doesn't have a car, or
right,
vice versa. If dad has the car assigned to him, but mom's bringing the child in and doesn't have a car assigned, like, we never know who's
the
going to bring the
same,
child in.
yeah. And that is part of, and I do apologize, I was late. So you all probably covered some of our more organizational suggestions and recommendations for how to improve NEMT, but One of those is, when you look at the broker contracts, they are required to collect the same information, including if there's mobility needs, such as a booster seat, a car seat, if someone is in a wheelchair. But broker to broker, region to region, the way they collect that information varies. And that is part of the problem. And so it's not to say that the screening process, when someone is requesting a ride, doesn't ask those questions, but how it's being received and processed on the broker end varies. And that's why you still run into some of these inconsistencies region to region on whether or not someone shows up with the appropriate vehicle or mobility supports. And so the same principles would and should apply, that if it's for a child and a car's with mom, but dad is actually using it to go to work or school, the same approval thresholds should apply, but depending on the region, depending on the broker intake, that is where the inconsistencies are happening still, I'm afraid. Is that helpful?
Yes, yeah, thanks.
So Justin with transportation is on vacation, but I do know Becky Downey is on, who helps oversee an EMT with Medicaid, and so she might be able to help answer those questions.
If you don't mind to put the questions in the chat, if I can answer them, I will, and if not, I will take it back to Jeremy and Justin if I need to.
Thank you. And I can gather questions too. If people want to email, if you have questions that you think of, email me and I can get those to Becky.
I will put my email address in the chat box.
And I agree. This is Dr. Terrio. I agree with what Kelly said. The problem is, I mean, it would be approved if the car is in mom's name and dad has it for work and he has to have it for work, it would be an approved exception. And so the child would be able to, use an EMT services with one adult to go to the visit. But like Holly was saying earlier, a lot of times it's difficult. Well, people don't know that, but then it's difficult to figure out what paperwork you need to get, because you'll have to get paperwork from the employer saying, the car is busy, and then to turn it in to the transportation cabinet. So that's another barrier.
Just to kind of thinking about next steps with all this information and the suggestions of advocacy opportunities to increase access to transportation under NEMT. So maybe the questions to Judy and maybe Kentucky Voices for Health. Where are we, and who do we need to speak to within Medicaid to kind of problem solve some of this and see what we can get changed?
I think Justin Derringer would probably be the appropriate person, and then Jeremy. We can't do anything without the transportation cabinet on, because like you guys said, they do a survey, like a satisfaction survey, but it's all good. It's real good. Oh, yeah. And Rachel.
Yeah, we have a presentation also on NEMT. So I think right at the end there, putting these two things together and coming up with those next steps, because I think we might be a little ahead of you, would be really great.
And I'm sorry, Rachel, could you say that again? What do you think about next steps?
Yeah, we have a presentation to go over with you all today on transportation and NEMT, and we address some things here and what we're doing and next steps. So I think that would be a really good time to bring this back to collaborate, because as Holly was going through it, I was nodding. No one could see me, but I'm nodding very forcefully. Yes, yes. So we're right there with you.
Oh, fantastic. Okay. So unless if there are questions, you can email them directly to Becky or to me. Any other conversation that for right now before we move on the agenda? Okay. So let's go ahead and move through some things on the agenda. A lot of these are follow-ups from prior meetings, and there may not be updates from DMS on these, but I wanted to just put them in as kind of placeholders. So there was a spa update, I believe, that was in the process on community health workers last year. Is there any update or information on that?
Well, I don't see anyone on that might be able to speak. I can tell you that the spa was approved. But outside of that, I will have to take that back. Is there any particular questions you'd like about the community health workers? And I can get that back. I don't.
I think it's just more what ended up being in the approved in the final spot implications and any implementation, things like that. Just a general update.
Sure. What I could do, the approved spa package is on the website, so I can grab that and attach it to your all's follow-up email if that helps. And then if there are questions, you can either reach out and let me know or put them on the agenda for next meeting.
Great. And then just wanted to point out that there is now an interpreter access flyer with all the MCOs listed and their numbers. So we're what's not on there is that number not on there. So just I'm not sure who put that together, but I had a patient with straight Medicaid, and I wasn't sure what number. So maybe the next version of that, I'm not sure who that came from.
And I apologize, you cut up a little bit there. Could you repeat that last part for me?
Yeah, I don't know who created that interpreter access flyer, so I'm not sure who to give that feedback to add who to call if they have straight non-MCO Medicaid.
Oh, I will add that on the take back. I apologize. They're doing some sort of drilling somewhere near me, so apologize.
Great. All right. This is the next thing on old business is just something that we've, obviously gone over since the beginning, and that is how's the cabinet using demographic data, race and ethnicity in their health reporting and looking at disparities and equity. That may come up under some of the updates. So maybe we'll do from that and see the exact.
Rachel, would you like to go ahead and give your presentation? I think it covers several topics. Or Leanna, I'm sorry. I think Leanna's presenting.
Hi, yes, this is Leanna Trainer with the Division for Quality and Population Health. Several of those topics that are on the agenda are covered in the presentation that we'll have. And we'll have several speakers just to touch base on those individual topics that are listed and welcome to any questions that the TAC may have from us.
Leanna, were you going to share or did you want me to? Oh, never.
Sorry, can everybody see that okay?
Yes, I can see it.
All right, Rachel, if you want to go ahead and get us started.
Sure, yeah, thank you. It has been a while since we've met, and we have been very busy with SDOH, and so wanted to give you all some updates and some information on what we've been doing, what's been implemented, and what we're currently working on. My name is Rachel Rarig. I'm the Manager of Research and Analytics in the Division of Quality and Population Health. And forgive me, it's been a while, so I can't recall if we had went over this one before or not. Excuse me. But one very exciting change that was implemented in 2024 is the state of Kentucky has implemented an overall SDOH needs assessment in the flow of the Medicaid application for renewals, for report a change, because those needs are going to change. That is uniform across all systems. So now if an individual were to call the DCBS call center or Connect call center, it's in their system to go through. If they were to go on their own through the self-service portal on Connect directly, it's there. It's also through Connect Resources website specifically. We've added this to all paper Medicaid applications and for the paper renewal. So we really tried to make this consistent across the board. And a big part of it was all states were really trying to come up with how do we get the best data for our Medicaid population of those SDOH needs. And a lot of them, pretty much the majority, went with the route of using the MCOs, which is understandable. MCOs house 90% of the Medicaid population in their managed care. But we did want to take a little step further and put it into the application and case part of Medicaid, excuse me, because this also is looking at our fee-for-service population, and that's that 10% of age blind disabled. So this is collecting data in an 18-question survey format for SDOH for our entire population, so we can see what that data is telling us. We can move forward. So in the system, what that looks like whenever we get this information, so for example, which best describes your housing situation, on the back end, depending on how they answer that, it's coded as it is either a critical identified need that needs to be addressed immediately, it's important, and it needs to be addressed sometime soon, or it's a stable indicator. So we do this for all 18 domains of our SDOH assessment. Can move forward. And with the paper application, we now have it translated into 15 different languages. So we wanted to make sure that assessment is available in all of those forms and for the application in each of those languages as well. So we're getting as much robust information from the population as possible. So what did we do with this information? This was initiated and implemented into our systems and across the board May 24th of 2024. So now we're able to collect a year's worth of data. So what we did is we have created an internal dashboard to look at and track this information over time. So looking at how many in our Medicaid population are taking that assessment. It's not part of eligibility requirements, so it's completely optional. It's something that is available if the member wants to partake in it and wants to complete that assessment. So from implementation from May 2024 to June, you could see, yes, as we all knew, there is definitely a need there. So we want to bridge the gap in between. We already have direct contact with these individuals. So instead of referring them somewhere else, to address that while they're there with us in a one-stop shop. So we're seeing that pretty consistent across the board with getting those SDOH assessments completed from our Medicaid population. And we can also drill it down between each region. And this is a collective view of the state. Move forward. So with that information, we don't just collect the information. It's fantastic. I'm a data person. I love data. But we also want to do something with it immediately. So what we've done is we have partnered with Office of Data Analytics and utilized the Connect Resources platform that has a United Way directory of all resources in that member's geographical area, all community partners that might provide that resource that they may not be aware of. So that way at the end of that assessment, they will be given the indicators. You have 3 critical need indicators, 2 important indicators, 15 stable indicators. Based on this critical, here are the different resources in your area that you can be referred to get help with that right now. So with that, we saw those referrals being sent, being in the housing domain as the top referrals so far for 2025 and also for 2024. So again, that's across the board. This is specific for our Medicaid members. We're also keeping an eye on the critical needs specifically, because we have 3 different domains that we're looking at. And of course, critical needs is going to be the most important. They need it now, it's urgent. So we looked at, before this was implemented, to make it more of a one-stop shop, if you will, the amount of critical needs reported was very low. Once it was made more accessible and more of a unified platform, you know, again, we saw what we thought we would, which would be that there are quite a lot of critical needs. Like any kind of rollout, we would expect to see a spike in the beginning and then more of a leveling off. This is the first year of implementation, so we are continuing to track that. And definitely seeing any type of correlation between policy changes or anything like that that might be happening and the critical needs count for our Medicaid members fluctuation. So what we're seeing time after time is exactly what Holly was talking about, transportation, which is why we started with it for this TAC to begin with. It's definitely something that we see, and we kind of have it known, but we wanted the data to back that up and to be able to track it over time. So we do see month after month transportation being quite high, fluctuating with housing, between housing, with the top needs, the critical indicated needs as transportation, housing, and life skills as the majority across the board, that with some slight fluctuations. Can move forward. So this is a very preliminary design for this SDOH dashboard with what we're tracking. So what we're currently in the process of doing is adding in the demographic details for our members that complete these surveys to get information on their race, ethnicity type, nationality, gender, age, primary spoken language, so we can really stratify it down further to see if there's any kind of consistencies that we're finding with particular demographics, with particular SDOH domains, particular referrals that are better for some individuals and are not for others. We're also working on, of course, critical needs is the most important, but we also don't want to forget about those important needs that are identified. So we are adding that in as well to see and track that over time. And we also have, we're in the process of adding a homelessness indicator so we can see of our members that are relaying this SDOH information, keeping an eye on that very fragile population as well, in particular, to see what we're seeing for them over time with those critical needs and how our policies and things that we do can hopefully affect that critical need indicator going down for that population. The next steps after we have this implemented, we're going to again partner with the Office of Data Analytics to create a citizen-facing dashboard, so a little bit different, less for internal policy and more for our community partners, so they see where there's SDOH deserts. And so there's community partners out there, and they might want to, you know, see, I'm looking at 3 different counties. I'm not sure which one I should develop this in, and they can see where it's going to be needed and utilized the most to get the most impact. And then also that kind of goes into our demographic data reporting. We are going to start looking at that. We're in the process of adding those stratified details into our internal dashboard. But one thing as well is we have a quarterly Medicaid enrollment demographic report that is currently being created and developed to be a ongoing report that we can utilize. And one thing that we want to do and to keep in mind as well when we're looking at the numbers is to be able to utilize and assess the demographic data that we're getting from our SDOH surveys and compare that to our Medicaid population to get a true representation of, is there a disparity here, or if it's 80, 20%, 10%, whatever it might be, is it also reflected here? So being able to align that information is something that's being developed as well. Okay, and then on to the very exciting thing with transportation access. So through that dashboard, our biggest discrepancy that we found, the inconsistency, was incredibly high need for transportation. That's very well documented within our data. What is concerning is that the referrals for these services are extremely low. So we looked at this and determined that with that contract between DMS and Department of Transportation with the regional brokers, that we are going to utilize that same referral platform, that one-stop shop that members are already being connected with, and adding the regional brokers there. So it will be based off of their geographical location. So it'll make sure it gets them to the right one. And it will make sure that that information is more out in a different public domain. They're already out there looking for resources. They may not know about it. They don't have to search a bunch of different websites. It's coming to them. So they'll have all that information in one place, and just a much more streamlined process to get connected with those NEMT services. We're currently working on system enhancements to the Connect Resources platform. And once that's completed is when we have plans to meet with transportations to discuss those next steps of adding the brokers into the system in order to be linked with members more readily to provide those services. And this right here might be a perfect opportunity as we go into that to take the presentation from Holly with those really great observations and questions and add that to the mix and work with our healthcare policy team in DMS to collaborate with them to bring this to our transportation partners' attention and to see how we can address that since we'll already be at the table with the referral discussion. So something that we could potentially do as well. Next slide. So this is what Connect Resources looks like. You can absolutely go out there and look on your own anytime. It's connect.ky.gov/resources. So this is if you were going to look on your own, you're not going through the application process. You could do it so many different ways. But if you were just out there exploring, this is what it looks like. Next slide. So with this, at the very top under that search function, I put in transportation. I'm in Frankfurt, so it's using my geographical location. And it's letting me know all of the resources that are available for that. That is the closest to me outward. So one thing that we noticed here is, it's great. We have Kentucky Transportation Cabinet Emergency Road Service. We need, this is where we need to put our NEMT. So this is something that would be based again on their geographical location to make sure it gets to the right broker. Cuts out a little bit more headache of trying to figure out who to call, when are they open, all of those things, because this provides that information. Next. So when you click on that little drop down, it gives you a little bit more information, a summary of it. So this one says Safely Assistance for Freeway Emergencies Patrol, sponsored by State Farm, is a free roadside assistance program to assist stranded motorists and improve highway safety. So it gives you an overall explanation of what the service is. If there are particular hours there, it's got that direct link to the website, the address where it's located. If you'll go to the next. Then at the bottom there, because it's just so long, there's so much information. There's also qualifications. So this is a really great place and a great resource to add that NEMT because we can put on there the different qualifications and get that understanding out there a little bit more as they're looking through this resource that they can be connected with. Any type of eligibility, next steps, what to bring, different languages that are provided. And at the end of looking at, and that's just pulling up one resource, it also has already in the algorithm of the Connect Resources platform, while that individual is looking at this, at the very bottom, it has frequently paired together and related services. So it's looking at people that have went to, say, the NEMT, this broker over here, and they're looking at it. They're going to go down and see where other members that went to that same page for that resource, what other things have they looked at, what's normally sent together in a referral for them to get those services. So just kind of helping them get some ideas if they wanted to continue to look for additional services. Okay, and that's all I have there. Was there any questions on that? And that's kind of the piece I want to talk about with next steps, because we're right on that same vein. We're going to be meeting with Department of Transportation and connecting this together So would that be a good point for us to bring in those concerns that Holly brought up there?
Great. So first, thank you so much, Rachel, and especially just the level of detail around the implementation is so important, and I think you're doing a really great job. I appreciate that very much. So I know Holly would be happy to talk to anybody about the information that she reviewed, and Aaron has the presentation. So what would be a good way, like, do you want to take things back, Rachel, and think about prioritizing, and then how do you see the TAC playing a role in this?
This is a very good question. Well, we will absolutely keep you all up to date on the progress of that connection into Connect Resources with an EMT and how that's going. But one thing that we can do is taking and leveraging the contract that we have with the Transportation Cabinet and addressing here are some issues that are being brought to our attention and working with them. How can we improve this? Let's cultivate some ideas on that. And then if they want any other type of, collaboration, Holly, if that would be okay, if we could reach out to you. But just get all the right people in the room to really, say, here's the problem and let's work together for that solution, and absolutely keeping the TAC up to date with the progress of that is kind of where my mind goes.
That's great. And then, yeah, bringing things back to the TAC, for example, if we really want to advocate at some point about changing the 72-hour requirement, it's probably a much higher level of discussion than, hey, let's standardize the intake process. So starting with some of the logistical things would be great. And then continuing to consider more kind of policy level things, I guess.
Yeah, that makes perfect sense to me. And one thing that we can do as well is once our division and the healthcare policy team meet and really have that discussion, we can also follow up with you all in email to let you know the outcome of that, of based on what we're doing here and what the different things that were brought up in this PowerPoint. This is our idea going into this conversation with transportation, keeping them up to date, things of that nature. Would that be okay, Julia? Just to send that on to you and let you know before those conversations happen.
That'd be great. And when is the meeting, the upcoming meeting?
Well, that's the thing. So the Connect Resources platform is currently going, it is underway of an update. So we cannot have them, we're not going to meet with the transportation representatives until that's completed, because there's not much their brokers can do until that's done. So at this point, we are working closely with healthcare policy and the Connect Resources team to stay on top of when that's implemented, so then we can get that on the books to be scheduled.
Great. Okay, thank you.
Yeah, absolutely. Thank you, everybody.
All right, thank you so much, Rachel, and thank you for that information. Again, this is Leanna Trainer, Division of Quality and Population Health. One of the things that was on the agenda was the interpreter access flyer. So we just wanted to provide some details about that. Of course, the update that it has been created. We do want to take back the information that you provided regarding missing that fee for service part, because we are expecting some additional edits in the future. This one specifically is a provider resource guide, but DMS and our partners are looking to develop a resource guide for the members as well. So more on those two topics. I did include a screenshot of that resource guide, just to give an outline of what it includes. So it just walks the providers through the process of either getting language assistance, assistance for anyone that's deaf or hard of hearing, or those that may be visually impaired. And this is available, these services are available either through their call centers, or there's also a process to schedule these for in person. So if they're in the office and they need those interpreter services, that can be available to them as well. So the next slide just goes into the different steps that a provider would need to take in order to get that scheduled. First, of course, would be determining the language need of the individual, and that would be done at or prior to scheduling that appointment. From there, the provider would need to look up the member's eligibility. So they'll see which MCO that member is assigned to, and they'll contact that MCO to make that request. And then the MCO will confirm the services. There is a requirement that those requests be submitted 5 business days before the appointment. So we are looking at the process a bit more to see if it can be more streamlined, but this is the details that we've provided on the interpreter flyer. Before moving on, are there any questions or additional feedback other than the missing fee-for-service piece? Hearing silence, I'll go ahead and move us on to the next topic. And that brings us to Troy Sutherland. He will discuss our work on the community health workers, specifically our focus study. So Troy, when you're ready, please.
All right. Thank you, Leanna. Good afternoon, everybody. Troy Sutherland. I am the Quality Branch Manager in the Division of Quality and Population Health. And just wanted to provide a quick update on some of the efforts that we're currently working on within quality, and specifically looking at community health workers and a focus study that we're currently developing. I'll note that to date, and from a quality perspective, there hasn't been a comprehensive assessment that's been done on CHW utilization among Kentucky Medicaid managed care enrollees. So we haven't quite done that yet, and felt like it's high time we, take a look at that piece. On behalf of DMS, OPRO, who is our external quality review organization, is planning to conduct a focus study to describe and quantify community health worker utilization, and thus identify strengths and opportunities. The study proposes to quantify access to CHW services among the Kentucky Medicaid managed care enrollee population, and to identify disparities and opportunities for improvement. I just wanted to quickly note that all the focus studies generally analyze services for disproportionate representation by, but not limited to, demographic, enrollee, and clinical characteristics, as well as health system factors and social determinants of health. The methodology on that is the first step. ALPROs assess the feasibility for each MCO report, selected data elements at the member level. Those data elements that all MCOs can report using the same measure will facilitate standardized measurement of CHW utilization across all MCOs. For those data elements that are not uniformly measurable, OPRO will conduct a chart review to get that information. Next slide, please. And that's a piece just on the background of the requirements for CHW workers and the reimbursements in the KAR, and the Kentucky General Assembly direction on that. And reimbursement for community health worker services shall be via appropriate codes that comply with relevant existing rate methodologies utilized by the department. I'm not going to read the whole slide, but just give you a little background on that, and some of the impetus behind us doing this study. Next slide, please, Leanna. So in doing this, that OPRO has proposed in conjunction with us the following objectives. Number one, the MCO employed CHW services will profile Kentucky Medicaid managed care enrollee receipt of MCO employed CHW services, including health system navigation and resource coordination, health education, promotion, and coaching for preventive care, the facilitation of care plan intervention, and social determinants of health referral and follow-up. The eligible population will be all MCO enrollees in each MCO information care system. And number two, the provider billed CHW services. That's going to profile Kentucky managed care enrollee claims for fee CHW services billed by providers by provider type. The eligible population will be all MCO enrollees with claims for the provider types that may bill for CHW services. And to note again that the study will be looking at January the 1st of 2025 through June 30th of this year for that study period. As I mentioned earlier, we're still working on getting this finalized. We're just nearly there. And I suspect the information that I've provided to you, there'll be very little change, if any, to that. We just have a few questions about some specific coding and provider types. But again, we're just about there and looking really to get that kicked off within the next month. We're excited to take a closer look at that and eager to get it kicked off and really excited to see, I think, what this focus study is going to tell us about CHW utilization. So, like I said, just a brief update. Any questions or comments about that?
Troy,
Uh,
the survey is just for the CHWs that are employed by the MCOs. Am I understanding that correctly?
I think it's looking at those employed by the MCOs primarily, yes.
Okay, so not necessarily community health workers that work with providers or health departments or other locations within the community.
Not specifically, we'll be able to look at provider billed CHW services to give us an idea in that area.
Okay, all right, awesome. That's great. Thanks for clarifying that.
Okay. All right. Anything else? Any other questions? I think I skipped a slide, Leanne. I think we can go to the next piece. All right. Thanks, everybody. I appreciate your time. If you have any questions or comments, you can certainly reach out to me. I can put my email in the chat if you have any questions, and I look forward to providing any sort of updates as we move forward in the focus study, and then potentially what we may end up doing with that information and how we will interact with the MCOs and what we find out. Thanks again.
All right, thank you, Troy. Moving on to the next topic, I noticed the racial equity core team was listed on the agenda, so we wanted to provide some updates on what that team has been doing. Since previously meeting with you, we meet every month. We do have Dr. Terrio that presents a different topic specific to disparities. Some of the examples that we've covered are listed there, one on maternal health morbidity, and then another on systemic racism experience with school-aged children. We have also included the featuring of video clips targeting specific barriers that people would be facing, designed to promote engagement and also start those discussions on some new approaches to addressing those disparities. So examples of some video clips that we have previously completed was the autism in school-aged children. And then the most recent one was effects of addiction. During the meetings, we also have a DMS division highlight their specific work as it relates to addressing and identifying barriers. And that also goes back to our racial equity action plan, just detailing those steps that they've taken since meeting last on achieving those goals. And we're also continuing to encourage the use of the GARE tool utilization, specifically the Government Alliance on Race and Equity Forum. Not only is it a forum, but it's also a process that helps to ensure that we're integrating equity into our decision making when making any kind of implementation changes, changes to policy, practices, or the program in general. In our most recent meeting, we provided or received some feedback regarding a request to analyze provider trainings that are offered by the MCOs. So we're currently looking to review not only mandatory but also optional trainings, looking at the content and the timing of those trainings to see if there's any room for improvement in those areas. Now, one of the big accomplishments of the rec team this year was we created a new racial equity action plan called the Population Opportunity Planning and Evaluating. This form specifically outlines the different cabinet level goals and then also provides a way to align them with those cabinet pillars. Each division was required to develop their own goals that aligned with the cabinet goals that were listed on this form. So the three primary goals that all divisions were required to review and consider are listed here. One was the gear tool utilization, and the ask was to have this utilized and reported by all branches by fiscal end year. Another is to enhance our hiring practices and ensuring that we're addressing both racial and intersection identities. And then implementing strategies to ensure that our procurement process and resource allocation is diverse and includes small business owners as well as women-owned or rural vendors. So just a snippet of that document, because it was 37 pages long. This is a snippet of the one of the main cabinet goals, which was on gear tool utilization. So there's a breakdown of the different goals that were identified in order for us to achieve that. And one of the activities that helps align with that goal was already starting in development before we updated this form. But DQPH specifically has embedded the gear tool in a standard operating procedure that's used by all staff in our division, so that we're ensuring that that tool is used whenever implementing new projects. Any questions on rec activities or any follow-up considerations that you would like the team to have?
No, thank you very much. Are there any questions that you might have for the TAC or any feedback that we could get from our even the TAC members not here?
Not directly, but just thinking of the different activities that the team is currently working on. If there's any concerns reported to the TAC that you can share, that would help our focus. We want to make sure that we're addressing the concerns internally and externally. So your feedback on anything that could be incorporated into those activities would be more than welcome.
When and I apologize, my I'm in the car. I'm not driving, but I had no cell service, so I dropped off for a minute there. When you were talking about the work that, say, Judy, when you're presenting things, are you all presenting equity data with race and ethnicity, or are you talking more in general terms of equity issues? I'm just wondering where we are and say looking at, mammogram rates by race and ethnicity or immunization rates, things like that.
When we
Right.
have it, we present it. Sometimes we don't have the breakdown like that, but yes, we do try and do it that way.
Thank you. And I know this is something you all are working really hard on, but are there opportunities that you've identified to get richer data around race and ethnicity that you don't currently have?
Yeah, so this is Leanna Trainer. I'll speak on that. There's a lot of different change orders that our division is currently working on to help with collecting and stratifying that data and to be able to feed up into the SDOH dashboard. And there's several reports that we have in review So we're looking at those different opportunities where we're not able to receive or obtain that data, and making the system changes necessary for us to be able to pull that at any time and for any project.
Great. So then it could then be used as well in the health data.
Yes, ma'am.
Great. Okay. Any other questions? Part of the presentation.
Absolutely. Well, with no other questions, I'll move us on along to the Medicaid Innovation Collaborative. And for that, we'll have Letha Harris speak on some updates from that group.
Hello, I'm Letha Harris, the branch manager for Population Health Branch, and provide you an update on the Medicaid Innovative Collaborative. And we'll go to the next screen. Thank you. So there were 3 pilots, and so I will give you an update on the first pilot, and it was addressing food as medicine, food as medicine initiative with Attain Health and Anthem as the managed care organization. Of course, as of this year, Anthem is no longer a managed care organization, but this pilot was during last year. As you can see, it was a 6-month pilot with 66 total members. And I won't read everything on the screen, but it was addressing members with diabetes, and they received a grocery credit to purchase items on the platform. So they had the ability to choose what they
I think we might have lost her. Give me just a
coaching
moment.
was an option, and that included supporting members in making improvements to care and behavioral changes. And then they also completed pre and post program surveys. Some of the outcomes as are highlighted there, a 70% increase in fruit and vegetable consumption, 74% trying new foods and cooking more at home. They 52% reported health improved during the pilot, and 90% through the coaching reported that they then improved their nutritional knowledge and management of health. But as we stated, these were pilots that were addressing members with diabetes in the Jefferson County area. And through this pilot, the pilot members showed a significant decrease in lowering their A1C levels versus a control group that did not partake in this pilot. All right, next slide, we'll talk about pilot number 2. And that was through Farmbox prescription platform and Passport, the managed care organization. And again, it went from June through November of 2024, and it served 165 members in Louisville with a diagnosis of diabetes and poor A1C control. And for this pilot, it was a controlled box that they received over the 6-month period. They received 3 pantry boxes and an alternated, and then 3 produce boxes that were delivered to their home. And we are to say that in 2025, Passport is actually expanding this to an additional 200 members, also with diabetes. The boxes also not only contained pantry or produce items, but would also come with some health educational materials covering a variety of topics, which included, reminding them to get their diabetic eye exam, some facts around continuous glucose monitors, healthy recipes, importance about, health risk assessment and staying in contact with your managed care organization. And another part to this pilot that was innovative was they partnered with Dare to Care Food Bank and Play Cousins Collective in Louisville. And that supported 8 in-person events for participants to come, and they would hear some health education, do a healthy cooking demo, and maybe have some group exercise activities. And then daycare was provided for members that were needed, and also transportation was provided for members that were needed. And they also received supportive tools such as a food journal and veggie pillar. So they also found that Managed Care Organization and Farm Box did provide that telephonic outreach support and reminders to participants. And then, as we stated, they were also offered transportation, which we've talked about that need. And so when you're offering those events, think how are people going to get to them? Some of the outcomes that they had were 77% reported improvement in blood sugar since beginning the program. 91% reported improved the access to healthy foods. 93% felt more confident in managing their blood sugar, and 88% reported a positive influence in eating habits. And again, these were both short-term food as medicine, but the outcomes and the impacts will not only continue, but were achieved during these short pilots. So very interesting. And as I said, Passport is expanding. So then we'll go to the next slide and talk about the third pilot. And now this was a pilot to address housing. And this was through the Samaritan platform with Aetna and Humana managed care organizations. And this pilot was able to serve 157 members in the Louisville area who have unsecure housing. They were referred through their community-based organizations and or managed care organizations care management through identifying members that might be in need. The Samaritan platform provides incentivized engagement where they can get credit for scheduling health appointments, inquiring about resources for food, housing, and transportation. They have access to harm reduction supplies and pharmacy access. So it's charting as they're taking steps to maybe, improve their lives. It is incentivizing them that they can earn some dollars or in assistance, which includes scheduling doctor's appointments. They received credits for transportation and for various needs, not only for medical appointments, connection to resources, and as we stated above, also to food and more. Some of the outcomes of those 157 members, 90% have been engaged with the program, and 93% of the care management goals have been completed, meaning they took some of those steps on that platform as they were directed. The plans report needing more time for these outcomes related to the participants to really determine that return on that investment. But I will share one member story here. They did in this short, again, pilot, mother of 3 completed 11 action steps, and she reported and increased her ability to budget income and will help her reach goals of financial stability. She was seeking and received resources to assist with her mortgage payment through this platform and engagement. And I'll go to the next slide and share another success story that came from one of the managed care organizations where they helped a member who they encountered that did not have secure housing, and they were unable to engage him using the Samaritan platform. And together, they set those goals. They were able to find housing, maintaining doctor's appointments, and then each month work with him on, accessing those resources. Because again, as we've kind of mentioned with Connect Resources and others, it's one thing to point them to the resources, but it's another thing to see that they get engaged, that it gets closed, and then they're able to receive those and really move forward. The community health worker, shared his story on the platform to see what other support could be out there. So they were able to get a list of low-income housing. They supported the member with following up with the landlord and assisting with securing a landlord who would take his voucher. And they helped with the inspections to ensure he understood all of the processes, secure some furniture donations, and help him to connect with the Goodwill program that will then not only provide him support, but also maybe furniture vouchers and some other things. So the impact, the member says he's very appreciative of this platform and the resources the community health worker helped him. He now has stable housing, and he is continuing at this highlight that was given just 2 months ago. He's continuing to participate in that case management because we know that engagement is so important. So I know, next slide, last slide for these updates. I did, in this next slide, post some links. So when these are shared with you all, the Center for Healthcare Strategies, which supported the Medicaid Innovative Collaborative, has published some documentation and posted some information around these pilots. And of course, we were not the only state to participate. So there were others that you could read about. And then there will be one coming out about the housing pilot where it just ended. There will be a formal report. And so that is an update for those pilots. And we were very excited to see the outcomes. And look forward to the future partnerships and collaboration.
All right, thank you, Letha, for sharing those updates. Moving us on to specific division updates. So DQPH has been working on a few different projects that intertwine with each other. This will go hand in hand with the next project. But the first one that we've started is an MCO community events. Essentially, we are monitoring and analyzing the different events that are being held by the MCOs throughout the state. We're interested to look at the content and the different demographics that are being targeted. We'll look to identifying ways that DMS can also engage with members. The hope is that we'll be attending some of these events and providing some outreach related specifically to Medicaid as well. In addition to the community events focus, we specifically are targeting maternal health. We do have a maternal health work group, so we'll be reporting those different events up to that group, as well as looking internally to see just what the different things that the MCOs are up to. We did provide some examples of the events that they have either already held for the year or ones that are expected to be held in the future of this year. So just examples of each MCO's different focus on maternal health is listed there. We did see 95 maternal health events from the time from January to June, and that's across all 5 MCOs. The main theme that was shared across all of them was there were baby showers, and there were 67 total during that period that was reported to us. The next slide will show just a graph of those numbers, a breakdown by MCO from January through June on the different maternal health events that they specifically held. Our next slide moves us into value-added benefits. So those benefits are extra services that are offered by the MCO plans that are not covered by the state Medicaid plan. Some examples of those would be gift cards for well checks, resources for getting your GED, or even coaching and testing support. And there's also some that have housing or utility support. The intent with this focus is to improve overall utilization of these VABs. It was determined that the utilization was less than 1% for 2024. There has been a slight increase in 2025, but those numbers are still low. So the team is looking to see what we can do to increase those utilization numbers. An analysis of that includes their redemption process, how complex or simple it is for members to get those rewards, and also a discussion aimed towards simplifying that process to make it easier for them to get those rewards. Another thing would be to analyze or identify, trends in those utilizations, as well as the community events that we'll be tracking to see if there's any correlation between improving or maybe even hindering those VAB scores. And then another point to make regarding VABs is the MCOs are currently working with the DMS to get onboarded to the Connect Resources website. And that was the website that Rachel provided a demo on. So the hope is that members will be able to go there and access the different VAB that would be offered by those MCOs. Another new project that we're working on is the opt-in text messaging. So a little backstory on that. There is a ruling and restrictions on how how entities can outreach to members via text and other methods, but our focus is mainly on text messaging. Our goal is to improve the communications with the MCOs, with being able to get members either enrolled to case management or making them aware of the various benefits, or resource opportunities that the MCOs can provide. This project does include updating the Medicaid application to specifically have a disclosure that would allow applicants to opt in to receiving text messages to whatever assigned MCO they receive upon the approval of their benefits. So it's looking to decrease the amount of time and effort necessary to start those communications with their members. The goal again is to improve VAB utilization, hopefully with at least a 1 to 2% increase, and also increase case management enrollment activities for those top chronic conditions as determined by DMS. The conditions that we are currently focusing on at this time are hypertension, COPD, heart failure, asthma, cancer, and diabetes. We will look and assess and alter those different chronic conditions as we learn more and as more statistics come in on what should be the primary focus. So another new project, just a high level, is on the 1915 I Rise initiative. That will specifically provide services to adults with a primary diagnosis of serious mental illness or co-occurring serious mental illness with an addiction. The 1915 I is administered jointly by DMS and BDID. So we're partnering with them to work through the requirements for that. Another project kind of aligned with that is the Recovery Residence Support Services demonstration. This will allow for reimbursement for non-clinical support services for individuals with SUD. And the work towards stabilizing them in their community by promoting independent living, a sustained recovery, and hopefully decrease relapse and reentry into the system. Yep. Sorry. So the last new project is the 1115 Health Related Social Needs Recuperative Care Pilot Program. And that's designed to allow for reimbursement for short-term clinically approved and appropriate housing and support services for individuals that are either experiencing or at risk for homelessness and who need recovery support after either a hospitalization or a planned medical procedure. Some more details to come while that team works through those requirements as well. And that's all of the updates that DQPH can provide regarding the agenda. If there's any other additional questions or feedback that the TAC has, please share. I'll also drop my email in the chat. We welcome any questions or any recommendations to altering our current projects.
Thank you very much. That was, there's a lot going on. You all are doing a lot of great work, and especially in the context of what else going on right now with the funding instability. And I know you all are super busy. Any other questions for the Division of Quality and Population Health? Great. Any update from still an Equity and Determinants of Health branch manager? And are there any updates there?
Julia, you cut out a little bit. I'm sorry. Who were you asking for updates?
Just number 4. Is there anything for number 4, number 5 on updates?
Equity and determinant. I think that was a little bit, some of that was included in Leanna's group's presentation. They oversee that area.
Okay.
Sure, and I apologize. This is Leanna Trainer again. That was not covered in the specific slides, but the Equity and Determinants of Health branch manager position, excuse me, is still vacant, but we are continuing the work, as you can see, with an equity focus in all of our branches.
Great. Thank
And
you.
then-
Yeah.
And then in terms of CHFS listens, the division specifically does not get equity related issues assigned to us. However, there may be other divisions or areas that may have a voice to speak on that.
Do you all get, so if there's if there's somebody that leaves a message or submits a comment there through then there's an ombudsman report, if I understand correctly, and then they would just be assigned to you if they were in your area of expertise.
Julia, so all the CHFS listen emails, constituent emails actually come to me and I disperse them out through whoever the subject matter expert is. I can ask, I'm assuming CHFS listens, I believe they were kind enough to pull a report for us once before. It had everything, and I don't know, I'd have to go back and look. I don't recall if it had the specific items that you were looking for, but I can reach out to them and ask them if that is still an ongoing report and something that they can share with me.
Great, that's great. I think it had come up before as an opportunity for the TAC to understand kind of what equity issue, if there are issues related to health equity that are coming through that we need to be aware of.
I'll request that. I know CHFS Listen gets a very large amount of different types of requests.
Thank you. All right, anything else under updates? Thank you. Okay, under new business, we've had this kind of on our agenda, but before, and not sure who to even ask about this, but as you know, we're a TAC that's not established in KRS. We just kind of exist. And is there an intention in the governor's office to then, would this be a TAC that's in KRS? Or are we going to stay separate from that? And we're not sure who to ask about that.
Good afternoon. I'm Jonathan Scott. I'm Chief Legislative and Regulatory Officer for DMS. I can address pieces of this, I hope. So, as you said, the Disparity TAC is not in KRS 205.590, which is where all the TACs are currently. There has been attempts and discussions about this in the past to try to put it in KRS. It's been drafted and discussed with some legislators here or there. If that is something you all are interested in doing, the language could be prepared, but there would be a need for us to have some assistance in contacting legislators and encouraging and getting the political will in place to move forward with that. So it'd be probably a longer process. As of right now, this TAC exists. It's a valid TAC, and it was created via executive order, so there would be maybe an uphill climb to try to get it through the legislature. We've had a little bit of trouble in attempting to modify the tax in the past. It's just it can be something that's difficult to build the political will around to do, but we would be willing to attempt to assist you in that. I don't, but you would probably want to do some work with your legislators and seeing what type of climate would be available if that were to be pursued during a legislative session.
Great, thank you. Yeah, I know there are pros and cons, we'll say, of pursuing this avenue. And maybe we'll revisit it when we have all of the TAC members situated, and maybe think about what would a roadmap look like, and then we can kind of make an intentional decision about potential next steps. So thank you. That's really, really helpful. Any other questions or comments on that? All right. just under general discussion, we have some time, a few minutes if anybody needs to bring up any new issues or things that we want to think about for future meetings. Oh, you're welcome, Wanda. You can share next time. I just to mention again, I know you all are under a lot of additional stress with all the changes going on nationally, and I know that you all are working really hard. And just thank you for doing all of the work you do in the context that you are working. I did want to bring up one potential opportunity. We know that lead exposure and elevated blood lead levels in children is a significant equity issue in different parts of the state. Certainly where I'm in Louisville, it's becoming a bigger and bigger issue. Where I was in Jackson County practicing, it was a big issue related to industry and parents working in industry and bringing home lead on their clothes. And I was hoping that we could submit just a data request from Medicaid on looking at some lead numbers and lead testing and payments and things like that. Aaron, can I just submit that first if people have any questions or comments? And Aaron, can I submit that as a data request to talk about at a future meeting to you?
Yes. So
Okay.
the only thing that I do request, because I'm not a subject expert, is I do request that if you can send me your data requests in writing,
Sure.
particularly if you want it broken down, by the NEMT earlier, you said you guys would like to see broken down by region, just so that way I can make sure to request exactly what it is that you'd like to see. So I'm happy to do that for you. And then we have about a 45-ish day turnaround before usually data gets released. Sometimes it's a little faster. Sometimes it's right around that 45th day. But I'm happy to do that.
Perfect. Yes, I'll submit that to you in writing after the meeting.
And I did have a quick update under general discussion. Sorry, I can't speak today. Since our next item is recommendations for the MAC, I did wanted to give you a brief update. The current MAC schedule has been canceled due to final rule, more federal changes. We have been working on implementing what we're calling the BAC. It's our Beneficiary Advisory Council. That is going to be comprised of lived experience, caretakers, advocates. 25% of the BAC has to be a part of the MAC. So we're working on restructuring and making our MAC, I'm calling it the big new MAC because it's going to be a little bit bigger. The commissioner of Medicaid will appoint MAC members and BAC members versus in the past, the governor's office has appointed those appointees. We are in the process of reaching out to all of our appointed BAC members to work on a meeting cadence. By federal rule, they are required to meet prior to the BAC. So we're hoping that the new MAC schedule will be coming out soon and that they will look to meet towards the end of September.
Thank you very much. And then obviously we don't have any recommendations, but will the process still be the same then? Would the TACs make recommendation
Yes,
to the
ma'am.
MAC or the BAC?
So everything TAC related will not change. You will still present your recommendations to the MAC, as will the BAC. I'm just letting everyone know our July MAC meeting was canceled. The final rule was implemented on 7/9, and our MAC meeting was scheduled for, I believe, the 26th. So that we did have to cancel that. And as soon as those new meeting dates are out, we will let all of the MAC back, and of course, all of our TAC chairs and TAC members know when those new meeting dates are set.
Thank you so much for that information. And then our next TAC meeting is scheduled for October the 15th. The information will be on the website. And then anything else before we adjourn? Just a huge thank you to everybody who shared information and attended. This is such important work and we appreciate you doing it.
Thank you.
Thank you, everyone. And all the presentations will be uploaded to the TAC website within a business day.
Great.
Thanks.
Thanks, everybody.